Right. Hello, everybody. My name is Amy Zozel. I'm a medical toxicologist at the Wisconsin Poison Center. We have a lot to cover today, so hopefully we can do it enthusiastically. You're going to learn a lot, and hopefully this will be high yield for you. So we have a lot to talk about: psychiatric pharmaceuticals, neuroleptic malignant syndrome, and serotonin toxicity. Here we go. So again, things that we'll cover, we're going to talk about atypical antipsychotics and newer generation antipsychotics. We're going to talk about cyclic antidepressants and non-cyclic antidepressants, and there are so many of them. We will try to focus on the highest yield ones with special pearls pointed out as we go. And there are a lot of non-cyclic antidepressants, more and more coming out, it seems like every day. And then we'll end this session with talking about serotonin syndrome and neuroleptic malignant syndrome, how to identify and manage them. All right, so starting out with antipsychotics. So antipsychotics are also called neuroleptics. They include phenothiazines, uh, butyrophenones, excuse me if I mispronounce some of these words as I'm going quickly, and other related drugs used to widely treat psychosis and agitated depression. In addition, some of these drugs like uh, prochlorperazine, promethazine, and droperidol are also used as very effective antiemetic agents. Suicidal overdoses are common, but because of the high toxic therapeutic ratio, acute overdose seldom results in deaths. Primarily, when toxicity is observed, it involves the cardiovascular and the central nervous system. And of course, severity of an overdose depends on dose and specific agents. So we can think of these in two groups. I really like to group and characterize things myself. It helps me keep track of the different agents and substances that we have to know. So we can think of them as typical or atypical antipsychotics. Typical are kind of the first generation, the original antipsychotics, primarily block dopamine receptors. Examples are the oldies of haloperidol, cloprazine, and they're used typically for the positive symptoms of schizophrenia or psychosis. These include the hallucinations, the delusions. These are more likely to cause movement disorders than the next generation or second generation, also known as atypical antipsychotics. These block both D2 and serotonin. And examples of these newer medications are risperidone and olanzapine. These tend to be used both for the positive symptoms like hallucinations and delusions, as well as the negative symptoms referring to social withdrawal, lack of emotion type symptoms associated with schizophrenia. Metabolic side effects are more common with these agents. So, what does the toxicity look like when these agents are ingested in either large amounts or we can see chronic toxicity as well? So, there's a variety of pharmacologic effects that are responsible for toxicity, primarily involving cardiovascular and CNS system. So, in cardiovascular system, we see antimuscarinic effects that can produce tachycardia. Alpha 1 adrenergic blockade can cause hypotension, especially orthostatic hypotension. With very large overdoses of some agents, we can see sodium channel blockade that results in a widened QRS interval on the EKG and potentially leading to dysrhythmias. And many of these agents can cause QT prolongation. In terms of central nervous system effects, we see centrally mediated sedation and antimuscarinic effects that contribute to CNS depression. Alpha 1 adrenergic blockade causes small pupils, despite antimuscarinic effects on other systems. Extrapyramidal dystonic reactions are relatively common with therapeutic doses and probably are caused by central dopamine receptor blockade. The seizure threshold may be lowered by unknown mechanisms. And we see oftentimes that temperature regulation is also disturbed, resulting in poikilothermia, and sometimes hyperthermia. So how does this look in terms of mild or severe toxicity presentations? Mild intoxication causes First, sedation, small pupils, and orthostatic hypotension. Antimuscarinic manifestations include dry mouth, absence of sweating, tachycardia, and urinary retention. Paradoxically, clozapine, an antipsychotic, causes hypersalivation through an unknown mechanism. So that's one to remember in terms of an outlier. In severe intoxication, we can see coma, seizures, and rarely respiratory arrest. The EKG can show QT interval prolongation and rarely QRS prolongation. Hypothermia or hyperthermia may occur, either hypo or hyper. And clozapine, again, as an outlier, can cause a prolonged state of confusion and rarely cardiac toxicity. Risperidone, aripiprazole, and quetiapine can cause QT prolongation, but delirium is less severe. Extrapyramidal dystonic side effects of therapeutic doses include torticollis, jaw muscle spasm, oculogyra crisis, rigidity, bradykinesia, and pill rolling tremor. We've probably all seen that. So slow movements, some rigidity, some of that lead pipe rigidity. These are more common with some drugs more than others. Patients on chronic antipsychotic medication can develop a neuroleptic malignant syndrome. And we're going to talk more about this at the end of the session. But this is characterized by rigidity, hyperthermia, sweating, lactic acidosis, and rhabdomyolysis, and can be life-threatening. There are some special situations when it comes to specific antipsychotics that are worth knowing about. First, clozapine, that one just keeps coming up. This is obviously not a first-line agent because of all of the kind of the special situations it's associated with. It's usually something that's used for more refractory psychosis or a patient cannot tolerate other medications. So clozapine is famous for causing hypersalivation. Again, we're not sure why, but just kind of that drooling, just excessive drooling. Agranulocytosis, so it can cause bone marrow suppression, another very scary side effect. So these patients have to be monitored while they are in therapeutic treatment. And an overdose, it can cause a prolonged confusional state, markedly longer than some of the other antipsychotics. Promethazine is another one to note. This is one that is associated with and has several reports of causing severe tissue damage after perivascular extravasation or intraarterial injection, including severe necrosis and morbidity. So that's just one again to keep on our radar as a special situation. So treatment. So how do we treat someone with antipsychotic toxicity? Sadly, there is no specific antidote for this. You may hear about bromocriptine come up. This is something that has been used here and there. We don't have the best data for it, but that is a buzzword that may come up for you. Um, Most of this is going to be symptomatic and supportive care, right? That is the mainstay of all of our the good work we do in treating our poison patients, symptomatic and supportive care. So for dystonic reactions, we want to give diphenhydramine or benztropine. For QRS prolongation, we can treat that with sodium bicarb, 1 to 2 milliequivalents per kilo IV. For hypotension from these drugs, these are usually the hypotension probably involves vasodilation caused by alpha-1 receptor blockade. So we treat these episodes with IV fluids and, if needed, a vasoconstrictor such as norepi. Theoretically, drugs with beta 2 agonist activity may worsen hypotension, but I would say start with fluids and then norepi would be a good second choice. For QT prolongation and torsades, that might respond to magnesium infusion or consider overdrive pacing if not successful with magnesium. And benzodiazepines can be helpful for agitation for these patients. All right, good job finishing up with antipsychotics, moving right along to antidepressants. Here we go. So we are going to start with the TCAs. This is really a kind of a classic toxicity. Tricyclic antidepressants were one of the first medications we used to treat depression. Unfortunately, came with a lot of adverse effects, and they were are very dangerous in overdose, which is why we have switched to non-cyclic antidepressants for the most part. When you think about a kind of a quintessential TCA, you think about amitriptyline. That is kind of I think, the gold standard in terms of tricyclic antidepressants. So these drugs have been effective for the treatment of depression. Unfortunately, they have a therapeutic, uh, uh, very narrow therapeutic window, i.e., a very high toxic to therapeutic ratio. So again, we try not to use them unless absolutely necessary, and then much smaller dose. The smaller the dose, the better. So substantial risk of hospitalizations and deaths are seen in overdose. Again, that narrow therapeutic window. It's one of those drugs where a 10 times a daily dose can be fatal. So again, this does not leave us much wiggle room between treatment and toxicity. The main effects and toxicity seen are in the cardiovascular and CNS, or central nervous system. We see anticholinergic effects and hyponatremia. Symptoms usually are really quick onset after ingestion, like 30 to 40 minutes after ingestion. And even though in the past, especially, we get asked, should we get a TCA level? They don't necessarily correlate well with acute toxicity. One other little side note is that cyclobenzaprine, or Flexeril, is a muscle relaxer. I could soapbox about that. It's not really a muscle relaxer per se, does not work at the neuromuscular junction. However, it is sometimes prescribed for muscle relaxation. It is structurally very similar to the TCAs. However, thank goodness, exhibits less cardiotoxicity and variable CNS effects when compared to TCAs. All right. So, again, typically, toxicity will present within 30 to 40 minutes of an overdose. There are several mechanisms that contribute to cardiovascular toxicity. We can go on and on. That could be a whole hour lecture on all of the different receptors that this dirty, dirty drug goes after. But here are some. So, anticholinergic effects and inhibition of neuronal uptake of catecholamines result in tachycardia and mild hypertension. Peripheral alpha 1 adrenergic blockade causes vasodilation and contributes to hypotension. Membrane depressant, that's our quinidine-like effects, cause myocardial depression and cardiac conduction disturbances by inhibition of the fast sodium channel that initiates the cardiac cell action potential. Badness. Metabolic or respiratory acidosis may contribute to cardiotoxicity by further inhibiting the fast sodium channel. In terms of CNS effects, these effects result in part from anticholinergic toxicity like sedation and coma, but seizures are probably a result of inhibition of reuptake of norepinephrine or serotonin in the brain, or other central effects. We could go on and on about all the theories that result in all the badness, but I think for the exam, this is kind of what we'll focus on. Unfortunately, patients, if they are going to die, often die within the first 3 to 4 hours. Death from ventricular fibrillation, intractable cardiogenic shock, or status epilepticus with hyperthermia. So we want to really be aggressive about recognizing and treating these patients. So as always, we're going to go symptomatic supportive care. We are going to support that airway. We're going to get our IVs in. If we do see QRS prolongation as a surrogate for sodium channel blockade, we are going to give that patient sodium bicarbolases. If patients are hypotensive, we're going to give them IVF, intravenous fluids, and pressors. We will give magnesium for QT prolongation, and we might even need to overdrive pace these patients for torsade de pointe. Consider cardiac pacing for bradycardia or AV block. This can happen as patients get sicker and sicker. Um, Seizures should be treated with benzos and barbs or any other GABA, pro-GABA drugs, propofol as well. We may get to a point that we need to paralyze the patient because of so much seizing and moving and agitation that we do need to paralyze them, sedate them, of course. But if we do that, we want to keep on a continuous EEG monitor to monitor for any further seizure activity. These are cases where lipid emulsion may be considered if, we're doing everything else and things are not going well, we're not getting the results we want. And finally, some patients may need cardiopulmonary bypass. All right, moving on to non-cyclic antidepressants. So there's many types of these. This is going to be kind of the biggest chunk of the talk here. We're going to kind of go through some different ones and then dive in a little more detail. So we've got selective serotonin reuptake inhibitors. These are the SSRIs. So some of these are fluoxetine, sertraline, citalopram, paroxetine. We've also got the SNRIs, the serotonin norepi reuptake inhibitors. Examples of these, venlafaxine, duloxetine, milnacipran. We have norepidopamine reuptake inhibitors or NDRIs like bupropion, and then others such as trazodone, mirtazapine. We'll touch a little bit on several of these. Most of the non-cyclic antidepressants are less toxic than TCAs or MAOIs, although we're going to touch on MAOIs. And just know that the serious effects can occur with these, including seizures, hypotension, cardiac arrhythmias, and serotonin syndrome. So a lot to keep in mind as we run through these drugs. So first, we're going to delve into MAOIs. They're not ones that we thankfully have to see a whole lot of anymore, but they were kind of right up there with the TCAs in terms of our first I think early drugs, early pharmaceutical attempts to help treat depression. So, MAOIs or monoamine oxidase inhibitors. Again, this could be its own hour talk, so we're just going to glaze over the important parts for the exam. These are used for severe depression, phobias, and anxiety disorders, way less than they used to be because we have safer drugs now, which is great. There's a first generation that contains such drugs as isocarboxacid. I don't know if I said that right, phenelzine. Second generation, like selegiline. The second generation tend to be less toxic and are actually used for such disorders as Parkinson's disease and ADD. We do see serious toxicity in overdose or interactions with other drugs and foods, and the list is big for that. Toxicity results from the release of excessive neuronal stores of vasoactive amines, inhibition of the metabolism of biogenic amines like catecholamines and serotonin, or absorption of very large amounts of dietary tyramine, which in turn releases catecholamines from neurons. So this is actually right out of the most current Olson's. I did cite them there with my download. There are all sorts of drugs and foods that need to be avoided for someone that's on an MAOI. And they're really fun things like beer, cheese, chicken liver. Chicken liver's not so fun, maybe, but sauerkraut's fun. Smoked, pickled, or aged meat, snails, soy sauce, all sorts of things, summer sausage, red wine, yeasts. So keep in mind there's a lot of different interactions here that we need to be mindful of. So when we think about the toxic reactions, we really kind of break them into four types. One is the food interactions, and this is really when we're going to see that tyramine is a dietary monoamine that is degraded by MAOI and the GI system in the gut. This inhibition allows excessive absorption of tyramine, which acts indirectly to release norepi, causing a hyperadrenergic syndrome. So this can be a big problem in interaction, typically causing tachycardia, hypertension, anxiety, flushing, diaphoresis, headache, and all the way in severe cases, hypertensive crisis that can lead to end organ damage, intracranial hemorrhage, myocardial infarction, or renal failure. So no messing around with those fun foods. Second is interactions with indirectly acting monoamine drugs. So MAO, monoamine oxidase, inhibits degradation of presynaptic norepi so that increased amounts are stored in the nerve endings. Drugs that act indirectly to release norepi, such as pseudoephedrine and um, and phenylephrine, can cause marked hypertension and tachycardia in these patients. Selegiline is not likely to cause this reaction because MAOB has a much greater effect on brain dopamine than on norepi levels. So that's one, I guess, silver lining there. Three is that we can see serotonin syndrome, which is, we'll talk a little bit more about this as we go, but that is a kind of a constellation or a syndrome of severe muscle hyperactivity, clonus, hyperthermia that can occur when patients receiving MAO inhibitors use even therapeutic doses of drugs such as meperidine, tramadol, dextromethorphan, TCAs, SSRIs, lithium. There's ecstasy. There's so many different combinations that can cause a lot of havoc. It appears to involve elevation of CNS serotonin levels via multiple mechanisms. And these patients can, of course, be pretty sick, have altered mental status with both neuromuscular excitation, autonomic instability, such as hyperthermia, tremor, um, and all of those other terrible symptoms. In the worst case scenarios, patients can be very agitated, diaphoretic, delirious, severe hyperthermia can lead to acute cardiovascular collapse and multi-organ failure. So we try to avoid that whenever possible. And number four, toxic reaction group with MAOIs is an acute overdose. So in these cases, patients tend to present with hyperadrenergic crisis and excessive serotonin activity. So um, the four types of reactions: food, interactions with indirectly acting monoamine drugs, serotonin syndrome, and then an acute overdose. There we go. So how do we treat these? Symptomatic supportive care, as always, of course, when we see these toxicities. Hypertension is largely catecholamine mediated, so we aim to use alpha adrenergic blockers like phentolamine or combined alpha and beta adrenergic blockers like labetalol. We can see that, and we try to use titratable IV antihypertensives because of the potential for rapid changes in hemodynamics. If hypotension occurs, it may reflect depletion of neuronal catecholamine stores, and in this case, anything direct acting is preferred over indirect acting drug, dopamine, for instance. So we want to be very carefully monitoring their temperature, their other vital signs, and their EKGs as they can change quickly. All patients that are symptomatic need to be admitted for at least 24 hours for continuous monitoring. Okay, shifting gears from MAOIs to our much more familiar group of drugs, the SSRIs. So serotonin reuptake inhibitors also come in different flavors. Their main point, the main thing that they do is they inhibit serotonin reuptake. Um, it reuptake transporters, and they increase the stimulation of serotonin receptors in the brain. So there are several different kinds noted here. There are selective serotonin reuptake inhibitors, SSRIs, like fluoxetine, sertraline, citalopram, escitalopram, paroxetine, fluvoxamine. There's the SNRIs, which are the serotonin norepi reuptake inhibitors. These are venlafaxine, desvenlafaxine, duloxetine, and others. We've got the SARIs, or the serotonin antagonist and reuptake inhibitors, like trazodone and nifazodone. And we have partial serotonin agonists and reuptake inhibitors like the SPARIs, like vilazodone and vortioxetine. So again, several flavors of these. So in clinical effects, again, we see most of them in the CNS and the cardiovascular um, system. So in the CNS, the usual presentation after SSRI overdose includes some ataxia, sedation, and coma, the syndrome of Inappropriate ADH and movement disorders can occur at even therapeutic doses. Respiratory depression may occur, especially with co-ingestion of alcohol or other drugs. Um, and we'll talk more about co-ingestions later, but more mild effects are going to be kind of movement disorders, maybe some myoclonic jerking, restlessness, anxiety. In more severe cases, we will see ataxia, sedations, potentially seizures, and coma. Cardiovascular effects are usually not as life-threatening, although bupropion and SNRIs can cause sinus tachycardia and hypertension, and citalopram and escitalopram can cause sinus brady and hypotension. These can be delayed as well, so very important to note possible delay with those medications. Um, we can see severe toxicity, including QRS prolongation, hypotension, and cardiac arrest in cases bupropion, citalopram, and venlafaxine, if I did not say that already. And then QT prolongation, specifically severe with venlafaxine and citalopram. And then, of course, also, especially if there's a combination, even more likely if there's a combination of serotonergic medications, we can see serotonin syndrome. Bupropion is certainly one to mention. It deserves its own slide. It is a norepinephrine dopamine reuptake inhibitor. So it is a drug that is marketed for depression and smoking cessation. It is a stimulant that can cause tremors and seizures. This is presumed to be related to the inhibition of reuptake of dopamine and norepi, and also cardiac toxicity, possibly due to the effects on gap junctions that can appear similar to sodium channel blockade. Other special mentions, tremor and seizures are common with bupropion. So I have in red the symptoms or the effects, and blue the drugs associated. So tremor and seizures are common with bupropion and occur occasionally after overdose with SSRIs, particularly citalopram and escitalopram, as well as the SNRIs, venlafaxine, and duloxetine. I know that's a lot. Trazodone can produce peripheral alpha adrenergic blockade, which can result in orthostatic hypotension and priapism. I would say it's probably priapism is due to one of two things, well, maybe one of three things. Not an uncommon finding in the emergency department, and oftentimes the patient is on trazodone. Moving on to an oldie but goodie, lithium. So much to say about lithium, could also be its own talk. So, lithium is used for the treatment of bipolar depression and other psychiatric disorders, and occasionally to raise the white blood cell count in patients with leukopenia. So, that's one of the things as it was being used initially. It was noted that, oh my goodness, it increases white cell counts. Also, this is a fun fact, this is a trivia. It was actually one of the components of 7 Up back in the day when people used to put all sorts of psychoactive substances in sodas you could buy at the drugstore. Serious toxicity commonly occurs, most commonly occurs with therapeutic use in the setting of acute renal impairment or with super therapeutic dosing in patients regularly taking lithium. It is a naturally occurring alkali metal and a monovalent cation that enters the cells and substitutes for sodium or potassium. Um, the mechanism in which lithium produces its therapeutic and toxic effects are not completely understood. You think after all these years, but similar with acetaminophen, there's some drugs that have been out there for so long and we're not exactly sure how they work. We do know that lithium has a similar size also to magnesium and competes with magnesium as a cofactor for several key enzymes. And we know that toxicity involves serotonergic and possibly dopaminergic pathways. Lithium is also thought to stabilize cell membranes. With excessive levels, it depresses neural excitation and synaptic transmission. And serious toxicity most commonly occurs um, with therapeutic use in the setting of acute renal impairment or with super therapeutic dosing in patients regularly taking lithium. I think I had mentioned it once already, which means it's probably pretty important. Acute overdose, in contrast, without any lithium being on board prior to the acute overdose, is generally less severe. So lithium usually daily dose ranges from 300 to 23, I'm sorry, 300 to 2400 milligrams. A therapeutic serum lithium level is zero point 0.6 to 1.2 milliequivalents per liter. It is excreted by the kidneys. And the toxicity of lithium really depends on whether the overdose is acute, acute on chronic, or chronic. The key differences being the total body burden of lithium and the availability or ability to eliminate the lithium. So it's one of those things, if you're on a long time, you've got it kind of in your interstitium, it's in your brain, it's in all your tissues already. So a larger overdose on top of that could be more harmful than someone that has zero lithium on board and takes an overdose. So just to go through this to kind of gel that point a little more. So acute ingestion of more than 20 to 30 tabs by an adult can cause serious toxicity. We will see that GI symptoms may predominate, and patients often do really, really well. Usually some mild nausea and vomiting. Systemic signs tend to be minimal and are usually delayed for several hours while the lithium distributes into the tissues, particularly in the nervous system. In general, again, this ingestion is less severe and is well tolerated. Acute on chronic ingestions occur when patients regularly taking lithium ingest a supertherapeutic dose. Because this patient's tissues are already saturated with lithium, toxicity is potentially more serious compared with an acute ingestion. Once again, they're more potentially more serious because of the additive effects with lithium already present in the tissues. Chronic intoxication may occur in patients taking therapeutic doses. Lithium is excreted by the kidneys, as we mentioned above, where it is handled like sodium. Any state causing dehydration, sodium depletion, or excessive sodium reabsorption may lead to increased lithium reabsorption, increased accumulation, and possibly intoxication. Common states causing lithium retention include, you can probably guess them, gastroenteritis, dehydration, the addition of a diuretic drug, particularly thiazides, use of non-steroidal anti-inflammatory drugs or angiotensin converting enzyme inhibitors, and um, and those types of patients. So patients that they're contracted in their volume and maybe their kidneys aren't working so well. Okay, a couple more things about lithium. We're getting there. So, it is a neurotoxin, um, primarily a neurotoxin, and the severity of toxicity is proportional to the duration of the lithium exposure and the amount ingested, of course. So now that we know about the acute versus acute and chronic versus chronic, we can talk about how that overlaps with mild or severe intoxication. Mild to moderate intoxication often results in lethargy, muscular weakness, slurred speech, ataxia, tremor, and some myoclonic jerking. Rigidity and extrapyramidal effects may be seen, although not so common. Severe intoxication may result in severe agitation, delirium, coma, convulsions, and hyperthermia. Recovery is often very slow, and patients can remain confused or obtunded for weeks, from days to weeks. Rarely, cerebellar and cognitive dysfunction is persistent, and this is referred to as syndrome of irreversible lithium effectuated neurotoxicity, otherwise known as silent, way easier to say. There have been some cases of rapidly progressive dementia as well, that have occurred and are usually reversible. Serotonin syndrome is possible in lithium, with lithium in conjunction with other serotonergic agents. And One last thing to note about lithium toxicity is people on chronic therapy, not necessarily people that overdose, but people on chronic therapy are at risk for nephrogenic diabetes insipidus, and they will present with dehydration and um, hypernatremia. So for treatment, unfortunately, there is no specific antidote. We treat coma, seizures, hyperthermia supportively. In dehydrated patients, we treat them with a lot of intravenous fluids. And then hemodialysis is potentially an enhanced elimination technique we can use, but please talk to your medical toxicologist before jumping to making a recommendation about that. It is very nuanced. So, excuse me. In summary, of non-cyclic antidepressant toxicity treatment, our priorities are going to be always provide excellent supportive and symptomatic care for our patients. We're going to be protecting the airway if needed. If patient is unable to protect the airway, we are going to give sodium bicarb often for QS prolongation, potentially magnesium for QT prolongation. We will treat hypotension and hypertension, hypo and hypertension as needed. Benzos or other GABA drugs for seizures, benzos for serotonin effect to treat serotonin effect to control agitation and tremor. We want to be able to recognize and treat serotonin syndrome, and we'll talk about that more later. And because of the potential for delayed onset of seizures or cardiotoxicity, observe patients for 24 hours after citalopram, escitalopram, bupropion, or venlafaxine overdoses. Moving on to our final section. Thanks for hanging in there. So next, we're going to talk about serotonin syndrome and NMS. And now that you know a lot about these drugs, I think it'll will be in a much better place to be ready to tackle these hot tox syndromes. So serotonin syndrome is essentially a consequence of excess serotonergic agonism of the central and peripheral nervous systems. It results from therapeutic drug use, intentional self-poisoning, or drug interactions. I like to think of it as a triad. I have the triad over here on the right lower screen of mental status changes, autonomic instability, which is essentially a, um, a term for vital sign abnormalities, the more concerning ones being hyperthermia in these patients, and then neuromuscular abnormalities, often some kind of neuromuscular excitation. It is also a spectrum of clinical manifestations. This is right out of one of my most favorite articles that I just happen to be clutching right now. I don't know if you can see it. Probably not. But anyway, my most favorite article, it is referenced here. The Ed Boyer and Mike Shannon wrote a landmark article called The Serotonin Syndrome in New England Journal of Medicine. It is from 2005, but I still think it's kind of the best descriptor in terms of describing the clinical picture as well as describing the rationale um, for serotonin syndrome. So the manifestations range from mild to life-threatening. As you can see here on this spectrum, so mild symptoms may be looking much more like a serotonin effect, all the way to full-blown serotonin toxicity. So for altered mental status, the patient might kind of on the low end, the mild end of the spectrum, have some hypervigilance, which then might progress to altered mental status, and then severe agitation and potentially seizures. Autonomic instability might start as some mild tachycardia and then progress to full-blown hyperthermia. The neuromuscular abnormalities may, again, begin very mild with a tremor, but then um, progress all the way to clonus and seizures. This is another clip from that article, again referenced below, this might be what a patient presenting with serotonin syndrome might look like. So this poor patient is hyperreflexia, and notably, the hyperreflexia in clonus is more profound in the lower extremities. Clonus, again, greater in the lower extremities. Has this patient has some autonomic instability, often hypertensive. She's tachycardic. She is agitated. She has some increased bowel sounds. She's diaphoretic and she has large pupils. So if you see a patient like this, I mean, other um, other tox syndromes may present similarly, but you should certainly be thinking this could be a patient with serotonin syndrome. This is the algorithm for diagnosis that was presented in this article, and it's pretty simple. Has a serotonergic agent been administered in the past 5 weeks? Seems like a long time ago, but that's what they used. Yes. Do they have any of the following symptoms present? Tremor and hyperreflexia, spontaneous clonus, muscle rigidity, temp greater than 38, and either ocular clonus or inducible clonus, ocular clonus, and either agitation or diaphoresis, or inducible clonus and either agitation or diaphoresis. If no, not serotonin syndrome. If yes, then serotonin syndrome. So on the right here are just some drugs that have been associated and well established for causes of severe serotonin syndrome. And so there is a long list. Some things you may um, not be surprised about, and some things you might be surprised about. Tramadol, linezolid, um, meperidine, SSRIs are not surprising at all, but again, you can take a look at this article that's cited here and learn more because there are a lot of potential drug interactions that can result in serotonin syndrome. I really do love this slide as well, taken from the same article. This really helps you differentiate between serotonin syndrome, NMS, neuroleptic malignant syndrome here, anticholinergic toxidrome, and malignant hyperthermia. So going through each of these, serotonin syndrome, you got to have a serotonergic drug. Anticholinergic, you got to have an anticholinergic agent. Dopamine antagonism is necessary for NMS, and malignant hyperthermia usually involves an inhalational anesthetic or a depolarizing neuromuscular blocker. This goes through the time needed for the conditions to develop pretty quick, especially for malignant hyperthermia, 30 minutes, but you can see a delay of up to 24 hours as well. Serotonin syndrome and anticholinergic toxidrome, usually we see symptoms develop within the first 12 hours. Neuroleptic malignant syndrome, a little more insidious. This can happen anytime during treatment as well, whereas serotonin and anticholinergic syndromes are usually with an increased dose or adding on a combo of another agent that is acting the same way. Neuroleptic malignant syndrome can happen anytime during the course of treatment with the neuroleptic, but maybe a little more insidious in onset. Like symptoms may start day one and kind of ramp up over days. So going through, they all can be hypertensive, um, all can be tachycardic, and then hyperthermia is the big one. We see the highest hyperthermia and malignant hyperthermia. Pupils might be normal for malignant NMS and malignant hyperthermia and will likely be large for serotonin syndrome and anticholinergic um, uh, as well. And then kind of going through some of the other, is the skin sweaty? Are the pupils large? But getting over to what I think is most important here is the tone, neuromuscular tone and reflexes. So for serotonin syndrome, we see increased neuromuscular tone predominantly in the lower extremities. We see that reflexes are hyperreflexic and that there's oftentimes clonus. These patients are often agitated and perhaps even comatose. Anticholinergic toxidromes, we see normal neuromuscular tone and reflexes, although they tend to be agitated and delirious. Um, for neuroleptic malignant syndrome, we see kind of this rigidity, this lead pipe rigidity, that if you're trying to move their arm, it moves in that lead pipe kind of motion. Also, lower reflexes. And these guys tend to be, or gals tend to be, have a stupor, or mutism, but alert, but they can be comatose as well. And then with malignant hyperthermia, they tend to have this rigor mortis like rigidity everywhere, um, which really does not allow you to even check reflexes on them and tend to be agitated. So that's a really nice summary chart. Feel free to look this up. It is a free resource. So finally, what are we going to do? And it's not always exactly clear. We might not have the offending agent, in a bottle in front of us. We might not have a great story, but um, the treatment for these is similar for serotonin syndrome and NMS. So we remove any of the precipitating drugs or agents that could be causing the problem. That has got to be number one. Number two, we are providing great supportive care as we always do. Number three, we're controlling the agitation. Agitation can lead to worse hyperthermia that then can lead to worse rhabdomyolysis, renal failure, and as we get hotter and hotter and hotter, our enzymes stop working and we can die. So control of agitation is key. Um, Benzos are great for that. We control autonomic instability by using all of our other symptomatic supportive care measures that we do. We control hyperthermia. Again, sometimes we have to actively cool people. Sometimes if they're getting very, very hot, we actually do need to intubate and paralyze them while keeping a continuous EEG on just to make sure that we are not missing any brain seizures because the muscles, if the muscles are paralyzed, they're not going to be showing us the seizure. So we're going to have to show ourselves with an EEG. So benzos, and other GABAergic medications. You will hear of some adjuncts, and we don't always reach for these, but potentially for the exam, they may ask about adding on a 5H2, I'm sorry, 5-HT2A antagonist like cyproheptadine. This can only be given PO, so it's not super not always super easy to give in someone that's agitated. And then you might hear bromocriptine as an adjunct therapy for neuroleptic malignant syndrome. So just again, we don't use those clinically a whole lot, but that is something that you may need to know those buzzwords. And that's it. So thank you so much for your attention. Please feel free to reach out to me with any questions or concerns. I know that was a lot in a quick session. So if there's other questions um, or if there's anything else I can help with, please don't hesitate to reach out. Thank you.